talk started, I probably made a version of this talk 10 years ago in the early 2010s, thinking about physical inactivity. And I got interested in that because I do have a background in exercise physiology and had been an athlete. And I just became interested in what we know about physical activity, what some of the barriers were, and just thinking about how that fits into health in general and what we know about health in general. So, let's just look at a brief history of death. Now, this is one of my favorite slides ever. It's from a classic movie by Ingmar Bergman in 1957 called The Seventh Seal. And interestingly enough, I picked this because it was about life in a pandemic, the Black Plague. And this is a knight coming back from the Crusades or coming back from someplace to Sweden. It's now under the spell or under the threat of the plague. And he is playing chess with death to see how long he's going to last during the plague, to remind us that life is very uncertain and things are a bit of a gamble, and you really never know for sure when your number is up. So this becomes quite interesting. And this is, sort of a brief history of death and thinking about it. So life expectancy throughout human history has been somewhere between about 25 and 30. This is 10,000 years ago, which is the beginning of farming, the Neolithic Revolution. And really nothing happens until the Industrial Revolution. Life expectancy doesn't start to rise until around 1800. And then it's fits and starts. Now, it started to rise for a lot of reasons: sanitation, better nutrition, and so forth. But it really took a long time for life expectancy to rise much. And this happened again because of the Industrial Revolution. And you can see what happened to human population. We've got the Old Stone Age, the New Stone Age. The New Stone Age progresses, the Bronze Age, the Iron Age, the Middle Age. And again, here's a drop in world population due to the Black Death. And not much happens to population. And then it begins to really take off at the Industrial Revolution as people began to live longer, and also because we were able to have things like agriculture and frankly feed more people. So we live in a very recent world, a very recent world. The world we currently live in is a couple hundred years old. Prior to that, the Industrial Revolution, not much had changed. Some of our tools got better. We had a little bit better food. Most people couldn't read. Most of us would have died of infectious disease, or many of us would have died of infectious disease. And life was short, dirty, brutal, and just tough until very recently. And you can see this, and this is a great slide because I had this in the talk before the pandemic. And so the thing that happened in the last 100 years until literally this year is death from infectious disease fell. So this is 1900 to a little over 2000. And you can see even not every state had a health department. Only about 40 out of, I think, about 46 states at this time, and certainly 48 by 1912 or 1912 when Arizona and New Mexico joined. You can see the death rate from infectious disease fell about 75 or 80%. There was this huge spike for the flu pandemic, and you can see things just kind of going down. Last human-to-human plague transmission, first use of penicillin, Salk vaccine introduced, a Vaccine Assistance Act, and so forth. And if you look at this, it went from about 800 per 100,000 to about 200 per 100,000 before antibiotics. So infectious disease until recently was conquered, not necessarily by things like antibiotics and even vaccines. It was clean water, sanitation, and public health measures that we've unfortunately had to relearn now and have degraded to some extent over the last certainly 50, 60 years. This is just
back up on that slide just quickly.
Sure.
Can you just give us your best estimate of what that spike would look like for 2021?
Dennis, you read my mind.
Oh.
This morning's New York Times. Here it is. So there was about 100 million people in the 1918 flu epidemic. And you can see there until that time, about 1 million people were dying per year. And you can and you can see that the flu pandemic really increased that by about 500,000, 400,000 in 1918. And then you can see more and more people die per year because the population is getting bigger. And we now had about 2.8 million people dying per year out of a population of about 340 million, 330 million until the flu pandemic. So you see this big spike right here. So it's very, very, very unusual, Dennis, to see anything that shows up in these statistics. So you got to have a whole lot of deaths to show up in these sorts of statistics. And I'll show you something in a minute. And there were certainly big time flu outbreaks and other things from time to time that were big, but they do not show up here as a spike. So this is quite interesting. And so again, there you go. Now, something like this did happen recently. This is the 57 flu pandemic, which is about, maybe a third as bad as this one. 116,000 people died out of 170 million. And you look what happened here. There was a wave, a second wave, it dropped down, and then a third wave. And there were all sorts of fits and starts before it went away. This is 116,000 people out of 170 million. So that'd be 220,000 dead out of the, if it was bad as the current situation, because the population is doubled, or 200, it'd be 232,000 dead. And remember, the population was much younger and there were no ICUs at the time. So if the population structure had been the same in terms of as many older people and so forth as we have now, there probably would have been about 400,000 people die from this. And so it would have been about maybe a 2/3 or half as bad as the current outbreak. But again, because the population was quite a bit younger, there weren't nearly as many people over 65 in 1957, only about 8% of the population. And now it's, I think, about 20%. So that really makes a big difference in who dies from infectious disease in the current environment. So things like this have happened. They haven't been as bad. We've certainly been worried about another flu pandemic like this one. There was another one in the late 60s. People thought there was going to be one in, I think, 2005, H1N1. Didn't emerge, but people were certainly worried about it. So you can see what happened is, again, and this is a data into the 2000s. So infectious diseases fell. They started to go up again a little bit prior to the current pandemic as more and more immunocompromised people and older people were living, but in general, infectious disease fell. And this is a log scale. Cardiovascular disease went up, and cardiovascular disease has come down remarkably as a result of smoking control, blood pressure control, and better treatments and things like statin drugs to reduce cholesterol. And you can see that cancer went up. Cancer started to go down a little bit. It's gone down some because of better treatment, some because of screening, but primarily because just smoking has gone down into society. About 80% of the improvement in cancer deaths in the last 30 or 40 years during the war on cancer since 1970, really the last 50 years, has been due to smoking control, tobacco control. And I think at one point, 40 or 50% of adults smoked. And it's much lower, less than 20% now. And essentially, almost nobody with a college degree smokes anymore. So it's really become a marker of almost educational and social status, which is of note. So we've gone from a situation until very recently this year where infectious disease over the course of 100 years went from being the biggest killer to things like cardiovascular disease and cancer being the biggest killers. And that gets you thinking about, what are the determinants and what causes those things and what can you do about them? Now, the other thing to think about is a demographic pyramid. So this is Scotland. It could be any Western country. This is 1911. You can see there are a whole lot of young people and there aren't that many old people. Whole lot of young people, not that many young people. A whole lot of young people, not that many old people. So this is a pyramid. Now, what happened is as infectious disease started to be conquered, and especially childhood diseases started to be conquered, you get this sort of flattening here, and you get the beginning of the baby boom down here. So people don't die, and you have now an aging population, a kind of a middle-aged population here. Again, still not a whole lot of old people, but more older people. Then you go to 1991, here's the baby boom, people my age, people that were born after World War II between 1946 and 1964. You can see people are living a lot longer, and there's a whole lot more older people, more women than men. And you can see now there's a bit of a baby bust. This is a projection in 2031. Again, here are the baby boomers moving through this like a rodent in a some sort of a snake. A whole lot of old people and not so many young people. So this has a whole lot of implications. A lot of what we're facing in this country relates to this. If you set up a social insurance program, Medicare, Medicaid, Social Security, when the population structure looks like this, you have a whole lot of people paying into a system and not that many people taking out of the system. When you get like this, you're still okay. When you get like this, it starts to get tough. And now the question is who's going to pay for all these people? Because you've got a majority of the people less than working age or greater than retirement age. So the number of people working and contributing to the economy compared to either people that are too young or quote too old to be a part of it is problematic. And you've gone from a situation where there's 5 or 10 workers for everybody receiving a social benefit to a situation where there's 2 or 3 or 4. And so those are the things we have to think about. And it's been said that demography is destiny. So one of the great things that's happened is infectious disease was conquered, life expectancy increased, but it brought a separate set of problems with it. And that those are the problems of an aging society and the economic viability of a society where you've got a limited number of people in prime working years and more people either younger or older than those people in prime working years. And here's something that's really, really quite interesting as well. So, 2045 is going to be the first time in the history of Earth where there are more people over 60 than under 14. And look at how rapidly that's changing. And if you'd gone back to that population pyramid, imagine what that would look like here. Imagine what that would look like here. And already in countries like the United States or especially Japan, you have large numbers of people over 65 relative to people say under 15 or under 21. So the world is getting older. The world's getting older, and this is for the first time in history over the last 100 years. You now have more old people than young people in many parts of the world. Again, something that would have been inconceivable in 1900, inconceivable. So how did this happen? Well, there was really, there wasn't evidence-based medicine. There weren't a whole lot of traditional interventions in hospitals or doctors' offices. A lot of this was public health based on hunches and epidemiology. So the very beginnings of this in the 1830s and 1840s was before we knew about germs. There were a whole lot of unintended consequences of industrialization. When James Watt invented the steam engine, he wasn't trying to make people live longer. The built environment matters, the built environment matters. So it both in a good and a bad way. You could have big cities that were incredibly unsanitary, that were just made for these sorts of infectious disease outbreaks, or you could have new cities with good sewer systems and so forth. Does anybody here know about the rebuilding of Paris? Has anybody ever heard about that? So sometime, somebody raise their hand? Tell us what you know, Colin.
Only a very limited amount, but I think I remember hearing about this in AP European history,
yeah,
if I recall. And yeah, they restructured like a whole lot of things, including I think the streets, right? I believe that's when they like installed the like large boulevards and things like that.
Yeah,
and
large boulevards, and they were worried about a revolution, a workers' revolution, because there were so many slums and the living conditions were horrible. They cleaned up the city, cleaned up the streets, and there was this incredible guy called Huysmans who did this, an engineer. So they re-engineered the whole city and built a modern Paris. And they did that for political reasons because they were worried about revolution, and that there would be no way in these dens and kind of slums that they would be able to send the army in to suppress the workers. Now, but in reality, they also delivered clean water to people and cleaned up the city, and people started to live longer. And so there's a whole lot of unintended consequences associated with that. Things like anybody know where canned food came from? And basic ideas of food sanitation. Napoleon, because he needed to be able to feed his armies. And they recognized early on that things that we would call sanitation now, poor sanitation, had killed armies. So again, a whole bunch of things related to food preservation occurred in the 1800s due to war, that ended up having big impacts on the rest of us. And what happens is what we've experienced here with this kind of rapid aging of the population and a suppression of infant mortality and infectious disease. It has happened in the developing world and can happen very quickly there, very quickly there. And which is obviously a good thing because you don't want people dying, but it can also cause big population problems for them as well. And remember that life expectancy has doubled in the last 150 years. And there's no genetic explanation for that. It just has happened because of the built environment. And the other thing to remember is to ask yourself how much of this doubling of life expectancy is due to the sorts of medicine that people like Dennis and I do versus public health. Anybody want to hazard a guess? So probably 3/4 or 85%. So if life expectancies increased in rich countries, say 40 years, probably somewhere between 30 and 35 of those years are public health based. Vaccines and things like infant mortality and sanitation. The rest of it is things like open heart surgery. So as wonderful as what we do in organized medicine is, and in high tech medicine, it hasn't done nearly so much as just clean water. So the civil engineers have beat the doctors by a lot. So now let's just think about inactivity, because this is what I think about. So this is what we would have been living like 200 years ago. If you were lucky and you lived 50 or 100 miles west of me, you'd have been out here hunting buffaloes. And if you were unlucky, you would have been a peasant farmer. And as somebody once said, Jared Diamond, the famous thinker about these things, said that the craziest invention in the history of humanity is agriculture. Why did anybody give up a low density lifestyle full of food to get involved in subsistence farming? And you can actually look at the data. If you look at skeletal remains from people that were hunter-gatherers and in situations where there were plenty of food like this, and you compare those to people that had started farming a few hundred years later, these people are smaller, their teeth are worse, and every element of skeletal, they had more infectious disease, every element of skeletal health is worse. So why people stopped doing this and opted to become peasants is just a great mystery. It's a great mystery. And nobody really has an answer for it. But it's sure something to think about. So now, how do these people live? These are the Amish. The Amish, if you've ever been here in the Midwest or in Pennsylvania, are a religious sect from Germany and Central Europe and places, and they practice non-mechanized farming. They really reject a whole lot of technology. And here's a man, farming in a traditional way. And what's really interesting is a friend of mine, Dave Bassett, went out and put pedometers on these people. He got them to agree to be a subject in his studies. And these are the number of steps per day they were taking. And this is 10,000 steps per day up to 30,000 steps a day. The public health guidelines say we should get 10,000 steps per day. And you can see that almost all of the men but one got at least 10,000 steps a day. And some of them a whole bunch of them got 20 or 30,000 steps a day. The women had fewer steps, but again, almost all of the women got 10,000 or more steps, or were very close. Now, what do you think about the body composition of these people? And they eat a lot. So the average number of steps was 18,000 for men, 14,000 for women. Men had 10 hours a week of vigorous activity, 43 hours a week of moderate, and 12 hours a week of walking. Anybody here walked 12 hours this week? The women did less, but still a lot, 3.4 hours of vigorous, 40 hours of moderate, and 6 hours a week of walking. Higher levels of energy expenditure. A total of 25% of the men and 27% of the women were overweight. That's a BMI of 25, and 0% of the men and 9% of the women were obese. So these people, and in the contemporary United States, it's about a third. A third of people are normal weight, a third of people are overweight, and a third of people are obese. This guy may have a BMI over 25 or 30, but it certainly looks like he's got some substantial muscle mass. So again, this is just what happens when you shift from a non-mechanized to a mechanized economy. And if you look at people who continue to do lots of physical labor every day all over the world, it's really, really difficult to get large when you do this. It's possible, but difficult. And many of these people, the Amish have plenty of food and they eat a lot because they have to. You know, you better have some mashed potato and gravies at lunch, or you're not going to have enough energy to go out and keep working all day long. And this is just some other interesting thoughts here. Occupational physical activity, 1960, you had very few sedentary people having totally sedentary jobs. That's gone up from about 15 to about 25%. You had 50% of people getting moderate physical activity at work, gone down to about 15%. And the number for light has gone up. But again, anybody here ever seen a mailman walking around a neighborhood? Any of the students? A few. But one of the ways I always tell this when I give this talk live is anybody over about 35 or 40 will always raise their hand and say they've seen a mailman walking around. But many younger people have not seen a mailman walking around because they've been driving. So even jobs that used to be associated with very high levels of physical activity, like the mail carriers, no longer are. And this is people in 2009 that got no leisure time physical activity. And you can see the darker the color, the worse. And these numbers have only gotten really worse since then. And you can see there are large parts of the country where people, where 30, 40, 50% of the people get little leisure time physical activity. So they really do nothing. So it gets worse. These behaviors and risk factors cluster: inactivity, obesity, diabetes, blood pressure, and lipids. And of course, we're #1 in the United States. And this is a number of years ago, and it hasn't been updated, but the US, Mexico was trying to catch us. The US at that time, Natalie, had almost 35% of people that were obese. So this is the US, this is Mexico, Australia, England, other people were catching up, Canada, Korea had people had remained relatively trim in Korea and so forth. But again, these whether we all will level off at the same place is not known. But these trends are very, very disturbing. Very happened, Natalie. I think it's a combination of several things. I think that, you know, people began to eat out more, and you know, agriculture became hyper successful after World War II, and certainly by the 70s and 80s. So it was possible to give people a whole lot of cheap, tasty food, because these levels of obesity only require you to overeat about 100 calories a day, maybe even less than that. So out of say 2000, so only a small error signal. So I think there's very little physical activity. So you have, it's a combination of things: more food, less physical activity of all sorts. And so, yeah. And, you know, some people have argued that reductions in smoking have played a role too, because as Dennis will tell you, that people that smoked a lot were less, they weren't as heavy. So I think it's a combination of things of how we eat, what we eat. Certainly, you know, highly processed food allows people to get huge amounts of calories very quickly. It's tasty. The food is engineered to have you, you know, grab another bag of chips or another handful of chips and so forth. So I think it's any number of things. Supersize me. When it's in our book, Natalie, you know, when I was a kid, you got a small burger, about 10 fries, 8 ounces of a soft drink, and that was what you got at McDonald's, and it's 250, 300, 400 calories. You could have one of those for lunch the rest of your life and you're not going to get fat. But now it's almost impossible. And I think I have a slide in here to get out of a fast food restaurant for less than 1,000 calories. And you know, I wouldn't say it tastes good, but it certainly is sort of satisfying and wants you to come back for more. You know, salt, fat, cheese, good stuff taste wise. And again, these are how risk factors interact. This is number of risk factors: 0, 1, 2, 3, 4, 5. And this is all-cause mortality per 100,000 person years, cancer, cardiovascular disease. And these are people in Scandinavia, some women in Scandinavia. And you can see that if you've got, you know, 0 risk factors, meaning you're not fat, you're physically active, you don't have diabetes, you don't have hypertension, you don't smoke, your risk of death is 200 per 100,000 people years. If you've got 4 or 5 of these risk factors, it's a five-fold increase. You double the risk of cancer, or even more, triple the risk of cancer, and you again, perhaps a triple or even quadruple the risk of cardiovascular disease. So one of these is bad enough, but when you get them all, it's really, really tough. And again, people have said, well, what are the determinants of health? And, you know, some combination of the behavior and environment probably play a huge role. Access to care is a small role. And then genetics or biologically predisposing factors, probably only a modest percent. Now, people will argue about whether it's 80, 90, 70, but the point is the vast majority are in the environment, behavior, and access to care parts of this. Again, people will argue, you know, some people will say the environment's 50% and behavior is 20%, and so forth and so on. So you'll get arguments about this, but you won't get a whole lot of arguments about, if you take these 3 pieces of the pie, that they in fact predominate. So the other thing I like to tell people is physical inactivity, and this is true for many of the things we're talking about here. A little bit goes a long way. When physical activity, a little bit goes a long way. So one of the things that happened in the 1960s is humans started going into outer space, and these were very vigorous, fit fighter pilots. And these men would come back after a week or 2 in space, and they would be incredibly deconditioned. They'd barely be able to get out of the spaceships, and barely walk on the aircraft carriers. And so what happened down in Dallas in the middle 60s, a man named Gunnar Blomquist, in conjunction with a guy named Bing Saltine and Jerry Mitchell, and Dr. Mitchell is still alive, put 5 college students at bed rest for 3 weeks. And they took 2 athletes and they took 3 sedentary people, and they saw that there was this large reduction in their physical function over 3 weeks. But then they brought these same men back 30 years later, and you could see that 3 weeks of bed rest was equal about 30 years of aging, which is remarkable. So really, it does not take much. It does not take much to really, for inactivity, have really devastating impacts on your physical fitness. And as I'm going to show you later, physical fitness is generally associated with long life and health. 650,000 older Americans. These are the hazard ratio mortality years of life gain, and this is about 30 minutes a day of physical activity, and you can see you get about 80% of the benefit with just 30 minutes per day. So inactivity really takes fitness away quickly, and 30 minutes a day gets you a whole lot of benefit. And this is physical fitness or physical activity, the same or different. These are years of follow-up, and these are cumulative years of survival. These would be people that were really fit, or they could do more than 10 METs, 7 to 10 METs, 5 to 7 METs, and then people less than 5 METs. These are people that almost have trouble doing their activities of daily living. And you can see here that over 20 years, about 80% of these people were still alive. We're only about 50% of these people were still alive. And this is fitness. This is just physical activity, where you measure this on a treadmill. You just measure physical activity by how much movement people are doing per day. And again, the same sorts of things. Cumulative total mortality is much lower in people with high levels of physical activity than people with low levels of physical activity.
Mike, could you give us a snapshot of what 10 METs might be like?
10 METs would be the ability to jog 1 mile in 10 minutes. So fit, but a level of fitness that almost anybody can get to, especially anybody, you say less than 50. That would be 10 METs. And again, now this just shows you what happens if people change. So this is somebody who is unchanged, low or medium physical activity. Decrease from high to low is red. These are people that increase from low or medium to high physical activity. And you can see their mortality was going up, and it shifts downward. And unchanged high physical activity is best of all. So people with high levels of physical activity die at a lower rate. People who go from lower medium and get more physically active, shift their curve. And here's people that decrease, they do a little bit worse or don't change. So you want to be high, but it's never too late to pick it up and do more. Never too late to pick it up or do more. And again, these people were started in their later 50s, and this is all the way to age 90. Now, here's one of my favorite ones. So this is just people's ability to get off the floor. So this is a sit to rise test, and basically a sit to rise test is how hard it is for you to get off the floor, and there's ways you score it. And if you can basically get up off the floor with just one hand down, so you can stand up and use one hand down, you get 8. If you have to use both hands, you get 6 or a 7. If you really kind of struggle to get up, you get 3 to 5, and if you really have trouble getting off the floor, you get 0 to 3. And this is the percent survival in a large number of people over 14 years. You can see that about 93, 94% of the people who could get up survived. And this is independent of everything else: smoking, obesity, other risk factors. You can see people that struggled to get off the floor had much higher mortality, about 8% versus about 40% here. So that's really remarkable. Again, a very simple test of physiological function is so predictive of a future health outcome in the sense of mortality or survival. There's been this thought that people can get too much exercise. These are people that have completed the 90-kilometer cross-country ski race known as the Vasaloppet. And you can see that the more races you've done, the lower your standardized ratio of mortality. And again, all of the people who've even done one race was 0.5 compared to Swedes as a general. So they use the electronic health record, the medical record system in Sweden to look at everybody in Sweden. But it's really incredible that the more races you've done, the fitter you are, you still continue to get some sort of benefit. So you hear stuff about too much exercise, and you go and actually look for data that supports it, and it's really hard to find it, again, too much exercise. There was thoughts that, remember we talked about 10 METs, and this is the reduction in mortality as you go from people that could do 10 METs or 2 METs to about 10 METs. Again, probability of death goes from about 0.65 over, I think, about 10 years to about 0.15, and this is in a bunch of older people in the Detroit area. There's always this question about whether you continued to get more benefit if you got fitter. And again, you could see what happens as people got fitter and fitter and fitter. Their risk of death continued to go down. Now, it's buried a little bit because it's not quite as steep as it is up here, but it's still pretty remarkable. So the fitter you are, the lower your overall risk of death. And again, 15 METs sounds like a lot, but that's something that most middle-aged people can do if they stick with it. And it's clearly almost anybody can get to 10 METs, and certainly many can get to 11 or 12. There's this sort of physiological dark matter. So if you look at the total protective effects of exercise, which are substantial, just looking at from here to here, and you say, okay, how much of it's due to changes in risk factors? You know, they're in a more anti-inflammatory state. Their blood pressure is lower. Their lipid levels are lower. Other lipids are lower. They're skinnier. They're not diabetic, so on and so forth. And this is in from the Nurses' Health Study, 27,000 women who either did more than 15,000 calories a week of exercise or less than 200. And you start looking for cardiovascular disease generically and coronary heart disease specifically. You see that all the risk factors below they don't tell the whole story. They do not tell the whole story. So exercise is even more protective than it should be. So if you just total all this stuff up, you can only explain about 59% of the risk reduction for cardiovascular disease generally, and only about 35% of the risk reduction for coronary heart disease. So there's other things that exercise does. What are they? Well, it turns out it's very good for the lining of your blood vessels, something called the vascular endothelium. They probably make the blood vessels bigger. They make your heart rate lower, and they do some things that make your just something called vagal tone, which is keeps your blood pressure lower. You're probably protected from what's ischemic events. So if you do have a heart attack, your heart attack is going to be smaller. And more importantly, we just talked about this, is the social autonomy. People that are fit can continue to do things and engage in life as they get older. And I think one of the things that's been challenging, probably challenging for some of the people on the call, is just our loss of autonomy in the last year. But imagine yourself as somebody who has no autonomy at any times because you're not physically strong enough or aren't fit enough to just do your activities of daily living. And there are a lot of people out there, and we showed the sit to rise data later or earlier, and 70% of 70-year-olds can't get off the floor. 70% of 70-year-olds can't get off the floor. So we've really got a kind of a fitness and movement problem in the country. So fitness absolves other sins. These are people that have low cardiorespiratory fitness, moderate and high. And you can see that even if you can see that these are very low levels across the blue. So even if you're hypertensive, your risk is lower if you're fit. Even if your glucose is bad, your risk is lower. Even if your lipids are bad, your risk is lower. Again, it's shown several different ways. So, and my favorite one is there's something called the healthy eating index. And so the healthy eating index, if you score low on the healthy eating index, it's a risk for death, except if you're fit, proving that if the fire is hot enough, you can burn anything, including Big Macs. And here it is, the unhealthy eating index. These are people that are fit, moderately fit, low fit. And these are people that have low, moderately, or high unhealthy eating indexes. And you can see not much happens here, where there's a bit of a dose response curve for the people that are either moderately or lower fit. So eating healthy is a great thing if you're not very fit, but it's not quite so as important as if you are fit and physically active. So the interim summary is really like this. The Industrial Revolution changed everything. The developing world is catching up. The world is getting less active and fatter and older. These behaviors sort of cluster, and the behaviors that cluster also cluster with outcomes. Physical activity is underestimated as a risk factor. Remember, I showed you there's a whole bunch of things that you can't account for in terms of the protective effects of physical activity. Activity is good for all sorts of reasons. And again, it does not take much one way or the other. So now, what are the 7 solutions? And I want you to think about this more broadly, because I think you can look at these 7 solutions in terms of physical activity, but you could also apply them to better diet. You could apply them to pollution. You could apply them to almost anything that has anything to do with health. So 1, public health and the built environment matter. And this just shows you what happens as this is deaths from airily transmitted diseases went way, way down. Again, they spiked here. And look at how that's correlated with increases in, or inversely correlated with increases in clean water and sewage. So again, the engineers in some ways were far more important than the physicians and medical scientists. This is percentage of workers commuting by bicycle or foot. And you can see that percentage of adults with diabetes. Now, this is not the world's tightest correlation, but if you start looking at this throughout an entire population, it makes a huge difference, Data from the United Kingdom, where they've looked at, they have a huge biobank there. The biggest gene variance effect on body mass index is like 0.2 or 0.3. Active commuting is about 2. It's about 2. So, if you actively commute, it's about 10x the effect size of an obesity gene. Activity and income. Here's a real problem. Everybody here is if they're not high income, is certainly highly educated, and income and education frequently correlate. And most of you are on your way to being members of the upper middle class. And you can see this is King County, which is Seattle. This is a number of years ago. It's the no physical activity by household income. And so you can see the better off people are, the more likely they are to get some physical activity in a given day. And again, these behaviors sort of correlate. People that have high levels of educational attainment or socioeconomic status typically see some connection between their current behavior and the future, and follow guidelines. They don't smoke as much. They tend to be more physically active, tend to be a little bit less obese, especially women, and things like that. Adult playground equipment. This is in New York City, and it just shows that it is possible to have fitness equipment outside of a gym that you have to pay for. And the question, of course, is what kind of equipment are we going to have? I'm involved in a thing. I was just interviewed this morning by one of the local TV stations because it's been uncertain whether we're going to open up the city pools this summer, not so much because of concerns about COVID, but financial reasons. And when you start, making it more and more difficult for people to participate, when you start having limited facilities and so forth, and you have a big kind of pay to play sort of situation, that's not a good thing. And again, Dennis and I are old enough to tell you that the barriers to participation when we were kids were essentially zero. Were essentially zero. And that's really, really, really changed. And it's a bad thing. It's a really, really bad thing. And so we need to think about our playgrounds and our open spaces. And for those of you who are into bodybuilding and lifting, certainly you can get a good workout at a facility like this. So who pays for bad behavior? Should there be financial incentives? Should insurance premiums change? How do you do this? Because many of the things that kill people or raise costs take a long time to happen. And what do you measure? There's a Safeway plan where they charge people or give them a break on their health insurance if they don't smoke, if their BMI is less than 30, they're not hypertensive, they have healthy ranges for cholesterol and glucose. They work with you if you miss goals and try to get you down, and they again try to set up mechanisms to help people meet these goals. It seemed in 10 years ago, it seemed to be working. In terms of motivating some people to pass, and it is interesting though if you think about it. I mean, cholesterol, for example, there are only 17% of people went from a do not pass to a pass over a course of a year, and there are good cheap drugs that will make anybody's cholesterol get into range. Same is true for blood pressure. Same is true for quitting smoking. Losing weight is challenging, but again, there were significant financial incentives, and it just shows you how difficult this is. Should we have people pay higher premiums? So should we pay higher? Should we have people who have higher insurance rates, people who are significantly overweight, people who smoke? So people are a little bit more supportive of charging smokers higher insurance rates. I should look this up again because this has been a while ago, and to see if it's changed. But again, people don't necessarily want to hold others accountable for their behavior. Taxes and regulation: a 10% increase in cigarette prices leads to a 4% reduction in consumption. As soon as you have reductions or restrictions on smoking, you have a 15 to 30% reduction in admissions for cardiac events within a quarter. If you raise the price of alcohol by 10%, you can reduce alcohol attributable deaths through things like car wrecks by 30% very quickly. The biggest effects are on the poor and people in your age group. And people have argued for sugar, fat taxes, and food regulation, but the pushback is always, what about the nanny state? And this is what I said about the fast food earlier. So this is the actual calories in a meal, and this is the estimated number of calories. So the line of identity here is what's accurate. And you can see that kids have no idea how much they're eating. They get 2,000 calories, they think it's 500. You can see adolescents do a little bit better, but not much better. And adults still do pretty poorly. So people end up eating a lot more than they think in these sorts of screen time. Now, this has been a lot of fun for the last year. So here's odds ratio for being overweight or obese. These are people that have low levels of physical activity and high computer use. And people have called it, COVID-19 for the 19 pounds they've gained during lockdown. And this is almost a threefold increase of being risk, where people that have high levels of physical activity and low use of screens have low risk of being physically active. So what do we do about limiting screen time for ourselves, for our kids, for others? My friend Jim Levine, Jim has left Mayo, but Jim developed this sort of walking treadmill. But look at this, over the course of about 10 years, the number of kids in Massachusetts who were getting physical education classes once a week dropped from about 80% to 59%. And you can see that the number of kids who were at risk of becoming overweight went up as well. So, you know, how much physical, and now we had a lot of physical activity in the good old days because people wanted to make sure that especially the boys were ready for military service when that was more compulsory back in the 60s and 70s. Here, look at the effects of education on people meeting goals. So again, uneducated people have a hard time getting their physical activity, and highly educated people are much more likely to do it. Same is true for muscle strength. And there are somewhat analogous data in terms of body weight, not nearly as tight. Certainly for people in lower educational and socioeconomic bands, there are many barriers to physical activity, And it's completely inaccurate to say that those individuals don't want to be physically active or don't understand the benefits of physical activity when there are these barriers out there. Parental education matters. This is the obesity rate of kids. And again, this is 10 years old, and this is based on the college boards. I don't know how the heck the people who make the SATs or ACTs came up with this. But again, the more educated your parents are, the less likely the kids are to be fat. But again, you go to school and you go to a school full of well-off people with educated parents, and you talk about what did you do during the summer to the kids. Well, I had tennis lessons. I, went on the swim team, whatever it was. And you don't necessarily get those sorts of stories from people that are from less resourced homes. How about the social contagion? This is a great one. This is the obesity and smoking. So this is your friend. This is a friend of your friend. This is a friend of your friend, on to 6 degrees. So it turns out that if you're obese, the odds of you having first-degree friends who are obese is quite high, even higher for smoking. And you can see that this drifts down as you get farther and farther away. So some people have argued that you can use data like this to figure out where to target in social networks to try to increase physical activity, to try to increase dietary adherence, to try to reduce smoking. And the people who think about these things are, rather than intervening over the entire population, what you might want to do is intervene more in a more targeted way within small social networks. Make better choices the default choice, and this is just Germany versus Austria for organ donation. So really not physical activity or health. But in Germany, they say, do you want to be an organ donor? And 12% of people say yes. In Austria, which uses opt-out, where people have to say, I don't want to donate, or the theory is they're going to donate, very few people opt out. So that's one of the things about nudges and choices that people have to think about. And medicalize it. Physician advice works. Do you want to turn every single problem into a medical condition? Physicians have to have empathy. They have to have time. They have to set a good example. And again, it's very easy for me to write somebody a prescription. It's harder for me to send them to the gym. Now, this is Cuba. So in Cuba, they were getting subsidized by the old Soviet Union, and that went away for a couple of years in the early 90s. So what happened is that energy consumption went down. And you can see here, dietary energy intake went down and physical activity went up because they didn't have any fuel, didn't have any oil from the Soviet Union. And the obesity prevalence and the diabetic incidence went down as well. When the economy recovered, people started to eat more again. They became less physically active, and then went right back to where it was. So how about all of the above? So you got to think about the environment. You got to think about incentives. You got to think about things like syntaxes, screen time, education. Think always about who you know them. What do you medicalize? And I think the main thing is, how do you as a society make the smart choices easy and the dumb choices hard? And don't forget the nanny state. Remember this. This is one of my favorite slides. Government, keep your hands off my Medicare. The government is Medicare. So we have a lot of people that are just uninformed about who's spending what on health, where healthcare spending comes from, and who's paying for it. And it's exemplified by this slide here. So remember this. civilizations die from suicide, not by murder. And what we're doing to what the outside world is doing to us, and what things like this horrible virus do to us, are things of note. But a lot of our problems are self-inflicted in our ability to kind of face reality and take reasonable steps to alter that reality.